Hello, my name is Nelum. I'm a GP from Australia. I have a particular interest in the South Asian community. This group of people are very high risk, and they are iller at lower BMIs. And they tend to fall into the TOFI category, thin on the outside and fat on the inside. So my question really is to Mariela and Cynthia, have you had much experience treating this group of people, particularly with their cultural conditioning?
Yes, actually. I've had a lot of experience treating TOFI, and it responds beautifully to keto, low carb. Because essentially, what TOFI, I always think of it as you just don't have enough fat cells subcutaneous to become an insulin-sensitive obese person. So you immediately start doing ectopic fat, and that is very problematic. But it works. It works great, especially fatty liver. I see that really melting away very, very fast.
I 100% agree. I would also indicate these are the types of patients that do particularly well with intermittent fasting in particular. They do beautifully well along with the macronutrient changes.
Thank you.
Yep, I agree. Never argue with two women.
Yeah, I'll just add because we talked about the metabolic inside being problematic, and yeah, low carb restriction definitely seems to improve that in many ways. But the thin part, I think you got to add resistance training and enough protein. I think that's a big, important part of it. Because we have just as much to have an obesity epidemic. We have I think a frailty epidemic. I think that's a real problem. So you have to address both sides of the coin.
Thank you.
My question is primarily for Cynthia, but obviously for all of you guys. With the android versus gynoid phenotype, what do you think is primarily causing, beyond genetics, what would primarily cause one person to gather more fat in the viscera and liver versus store it subcutaneously? Are we thinking it's more fructose consumption versus, maybe starch is the reason somebody else would store subcutaneously? Or are we thinking more seed oils? Just kind of wanted you guys' thoughts on that.
Okay, so the question was, apple versus pear, men versus women. Obviously, there's a sex difference, right? So women are going to store. Why do women store body fat?
I will say, I got a DEXA scan. I'm technically gynoid.
Well, I don't know about that.
Per the DEXA scan.
Anyway, but it's interesting why we store body fat where we do. Biomechanically, it makes sense. Why, if I'm going to carry a big weight around, I'm not going to put it on the end of my finger. I'm going to carry it close to my center of mass. Males have a higher center of mass because of our bigger shoulder sizes than women. Women tend to have bigger, stronger legs and smaller shoulders, so their fat storage is going to be a little bit lower. So we typically see women have fat around the hips, guys have it around the bellies. Obviously, there's hormonal impacts on there. There's some genetic impacts on there. I don't know if any particular dietary strategy is going to favor where you store your fat. I think you store your fat where you store your fat is. And to my knowledge, I don't know if you can say if I eat more fructose, it's going to go to my hips versus if I eat more butter, it's going to go to my belly. There has been some analysis, actually, it's interesting that they look at, the different components of fat, like saturated fat versus unsaturated fat and where it stores in the body. Maybe diet has an impact on that, but it's not something I've looked in too significantly. Either you got too much fat or you don't. But belly fat, particularly visceral fat, we know is much worse, and that's why men have higher rates of heart disease, and women can have a little more body fat and do fine. So maybe there's an advantage. But as a male, I don't want to be particularly estrogenized. I think that's probably problematic for other reasons. But anyway, I don't know, Peter, if you have any insight.
Yeah, look, I think it's primarily hormonal. But one of the interesting things is I had a close friend, actually, who was, close to morbidly obese, but he had a combination, really, of both peripheral and visceral fat. And got him on a much better diet. And he lost all his peripheral fat, but didn't lose any of his visceral fat. And I can't really explain why preferentially you lose one than the other. Obviously, we know visceral fat is so important because basically it contributes to inflammation. Something I didn't realize for many years is that the adipocytes in visceral fat secrete inflammatory cytokines. So, you've got the the poor diet that makes you fat in the first place, which is inflammatory, and then on top of that, you've got the fat cells increasing the amount of inflammation. So you've got a double whammy in visceral fat. But I can't really give you a good explanation as to why one person develops it in one place and the other than the hormonal, male-female hormonal differences.
I would just add that in my clinical experience, I would say inflammatory seed oils and high fructose corn syrup, and we have Dr. Rick Johnson. Is Dr. Rick he might not... Yes, Dr. Rick Johnson is the expert in fructose. So, if you understand the physiology of how fructose is absorbed in the body and how it goes directly to the liver, that can help contribute to the visceral fat. Dr. Rick, is that a thumbs up? Yep, okay. Anything you wanted to add?
Yeah, no, I think that's...
Amazing. Let's go back over here.
Following Dr. Westman's rule, my name's Cassie Jinks. I'm from Tucson, Arizona. And my question's about the insulin-sensitive obesity patients. I love that you talked about that because I'm seeing more and more of these patients with really high BMIs and low trigs and high HDL, and I just try to wrap my head around what that physiology is. But so my question is, would you approach their weight loss treatment in a different way than someone who is obese and diabetic and has high insulin levels? If high insulin's not the problem, is it still really about restricting carbs, or do we need to think about this in a different way because maybe it's a different physiology driving the problem?
I can answer that too. Okay, I'll start. My approach to patients like that, the insulin-sensitive obese, is that I do tend to pay more attention to calories, and I do use more fasting because they don't respond as fast as the insulin-resistant patient. So that's something I learned from Ivor and Jeff in their book, and it actually turns out to work out pretty well.
I would agree, and then I would also really lean into the lifestyle piece, the sleep, the stress, all the underlying things that can exacerbate that, and depending on the age of the patient, really looking at sex hormones as a contributor, because I do find unfortunately, women north of 40, when they're in perimenopause and menopause, it just gets more challenging, and so really looking comprehensively at hormones and in addition to the lifestyle piece is very helpful.
Yeah, I agree, and I'd particularly emphasise stress. I think stress is and it was mentioned in the talks, it's such an underrated issue in sort of glucose metabolism and hormonal metabolism, and you can be on the best diet in the world, but if you're stressed to the hilt, then you're not going to win.
Yeah, I honestly don't often find that I have that information in front of me. It's so rare that someone's checking insulin that it's I kind of have more of a one-size-fits-all approach to obesity. And I think the first thing is, you didn't get obese eating vegetables, you didn't get obese eating steaks, most likely. It's the processed garbage, and you just got to address that basically addictive nature. And I just tell people, load up. I tell people ask me, how much meat do you eat? I say, eat enough so you don't want a damn cupcake. And that's my approach, and it works. And it may take 2 or 3 months, and they may not lose any weight, but once they get that freedom from being addicted to this stuff, and I think you really have to address it, because food addiction, it's a tough one, because you don't have to exist in society, you don't have to do cocaine, you don't have to do alcohol, you don't have to smoke cigarettes, but you sure as hell have to eat. And so they have to deal with that every day, multiple times a day. And so, like I said, it'd be nice to know, and maybe there are some differences in there, but I rarely have that in front of me to know the answer.
Amazing question. So there's a question in the chat here, and if all of you have questions and you don't want to ask at the microphone, you can type it into the chat. One was about stevia, xylitol, monk fruit, so non-nutritive sweeteners, concerns, opinions, perspectives from all you all.
Okay, I got the microphone. I think this is one of those things where the research obviously is very mixed on this stuff. People say, well, it's better than drinking Coca-Cola, right? So I think you certainly can make that argument. There's some concern around, does it impact the microbiome? Well, quite frankly, every single thing in the world impacts our microbiome, and the temperature does, whatever. So I don't know that is enough to dissuade me from using it. Now, I will say there are people that they just have to dissociate themselves from the taste of sweet for a period of time. And, you tell them, hey, you can have some stevia. Full disclosure, I'll have some of these little electrolyte packs that have a stevia in it. It doesn't bother me. I don't have any problems with that. At least I can't tell that I do. I think there's some that are better than others. Surely, things like, what are the ones, aspartame and things like that tend to be worse. Maybe monk fruit or stevia is slightly better. in some regards. But again, it tends to be highly individual. People that struggle with addiction. I literally see people that'll have one piece of Lily's chocolate with stevia, and they go on a 6-month bender. So I think you just got to, unfortunately, it has to be a little bit individualized.
Yeah, I largely agree. I mean, I think they're probably better than sugar, but not better than nothing. And there may be some that are better than others. The problem is that we've all become addicted to sweetness, and the food industry has done that very cleverly. And we, sweet is the new normal, and so sometimes it can be very difficult to wean you off that. But I think if you keep using the artificial sweeteners, you're not going to get rid of that addiction to sweetness. That is really important, I think, that as part of the whole program.
It's interesting. There was a non-nutritive sweetener study that was done in the fall, and it was comparing sucralose, aspartame, saccharin, and I don't know where anyone's still using that, and stevia. And it was looking the impact on the gut microbiome in mice over a 28-day period of time. And what was interesting is that oral glucose tolerance tests were skewed and not in the right direction. And so I always encourage my patients to really examine their relationship with sugar in any form. I'm a complete realist, and I do think that stevia and monk fruit are a bit more benign. I find a lot of people don't tolerate xylitol. They can find it very bloating and gaseous. But really understand, these are things we should be consuming sparingly. And obviously, if you're not insulin sensitive, they really need to be eliminated from the diet, at least for a period of time. Yeah,
I totally agree with you guys. I think the main issue for me is that people cannot really complain. I don't want to generalize completely, but I find that I have a lot more success when people are able to get off the sweetness addiction. So I really prefer to go without any artificial sweeteners. I prefer you even have a tiny bit of sugar rather than have the full explosion of sugar in your mouth with artificial sweeteners. I mean, you have patients that are doing, the whole thing with Diet Coke, and they're not getting better, and then you get the Diet Coke off, and sometimes you're surprised how much of a difference it makes. But other times it doesn't make that much of a difference, so it's kind of a tool that you can play with. And let's not forget what we learned yesterday about sorbitol, how sorbitol is actually making us sick. So, lots of things that we're still finding out.
I think excellent perspectives, and I'll just offer my opinion. I think from a biologic perspective, the non-nutritive sweeteners are relatively benign. I think the complication can be when you're having cookies, ice cream, treats that have non-nutritive sweeteners as the sweetener. The perception is that this is like a free ride. So if it had real sugar, you might only have a bite or two. But if it is sweetened with stevia, xylitol, you're like, oh, it's free. I'll have 2 or 3 pieces of the cake, pie, cookies, ice cream. So they can lend themselves to overconsumption. That's my only concern. But having a small amount, even during a fasting window, I don't think it's offering a supraphysiologic spike in insulin or glucose or leading to changes in fasting physiology. Great question.
Hi, my name is Kerry Campanella, a family practitioner from Lancaster, Pennsylvania. How would you advise us to respond to people who would point us towards some of the studies that have been published in the past couple of years claiming the superiority of plant-based diets with regard to parameters such as longevity and risk of heart disease and so forth?
I've answered this question before in the past, believe me. So I think, first of all, I just don't buy any of the research on longevity. I just don't think we can know. I don't think the evidence is anywhere sufficiently rigorous enough to make those conclusions. So first of all, I just disregard the premise. Now, when we talk about, what is a comparator group? Well, if you're eating, the garbage American diet and you cut most of that out and just eat carrots all day, yeah, you're going to lose some weight. But there are significant problems associated with a plant-based diet that are being shown more and more. There are studies on wound healing that shows they significantly have diffusion on wound healing. Osteoporosis is a big problem for them. I mean, that's clearly being shown. Study after study has showed increased fracture rates. There are numerous studies showing mental health issues with vegetarian and vegan diets, whether it's causal or, a response to, or mentally, people with mental health disorders choose to eat vegan. It's hard to say. So there's some definite limitations there. And I think the other thing is, while people, they'll point to the vegan bodybuilders and people that take the protein supplements can demonstrate that, the majority of the people tend to struggle with protein. I know it's considered a myth among the vegan community, but we consistently see people with vegan diets, and that's why they have fractures, because their protein quality is not good. So I think those are serious concerns. I mean, if somebody's ethically bound to it, that's a tough discussion, because you can take them to a field and say, look at all these dead bunny rabbits and mice, and this is from eating strawberries or whatever, and maybe that'll wake them up. But if it's just a health argument, it's a lot easier to show them literature that, at the very least, a non-junk food, non-processed food omnivorous diet is going to be far superior to the vegan diet. Maybe carnivore may be a stretch for them, but I just see a lot of vegan failures that go carnivore, and they almost have to do that to recover themselves. So yeah, I'll let somebody else talk.
Yeah, I think short term you often get good response with a vegan diet, and as Shawn mentioned, any diet's better than the standard American diet, and so you're probably going to improve your diet by going vegan. But it's certainly the longer term issues that I have concerns with, and I want to add iron to that to the list. That I think iron deficiency is a massively underrated, underdiagnosed problem, and I think if you're female and vegan, you're iron deficient by definition, and we know that iron. I think we're understanding more and more about the role that iron plays in so many different metabolic processes. It's a very underrated nutrient. So I have real concerns with iron and B12, but iron especially in vegans.
I echo everything else that my colleagues have said, but I would also say my concerns about these predominantly plant-based or plant-focused diets is that the macronutrient ratio, when you're looking at a piece of steak versus 6 cups of quinoa to get the equivalent amount of protein, most of our patients really need to be eating higher amounts of animal-based protein, less carbohydrate. And so I always go back to, does this make realistic sense? Beans and legumes, yes, I mean, intrinsically they can be healthy depending on the individual, but you can't make the argument to me that animal-based protein is not going to be a superior option. And Dr. Gabrielle Lyon, who you all will see tomorrow, will talk more about this.
Just recently I found out that protein eating has a big impact, or can have a big impact in the levels of uric acid in the blood. And that, at the same time, may have a huge impact on heart disease. And so I don't hear almost anybody in the protein-focused community talking about this issue with the uric acid. And I don't know if you see it, but I see it. And I'm wondering how to deal with that, because I don't want to be, having high levels of uric acid. It doesn't sound like it's a good thing.
Well, I don't think anybody eats protein by themselves. So I think I would imagine that, and we have the expert in uric acid here, so I would imagine that the context is what's important. In an insulin-resistant context, then you're probably going to be making more uric acid. But what do you think? Am I butchering this, Rick?
Yeah, no, I do study uric acid a lot, so... uric acid, besides increasing the risk for gout, in people who have very high uric acid levels, it's been found in plaque. And 85% of people with gout will have, using these new scans, will have uric acid crystals in their blood vessels, and particularly in areas of plaque. So it is something that's really important to discuss. But if you're on for example, if you're on a carnivore diet and you're on which is basically a low carb diet, you're not going to be developing, the uric acid is driving inflammation, but sort of one of the ways it works is to activate the fructose pathway and activate and stimulate fructose production. And so from glucose, and so if you're on a low carb diet, you don't actually have that. That bad aspect of uric acid isn't there. But the question of whether or not it can still crystallize in the blood vessels is a good one. Today we heard that a low carb diet, even with the high cholesterol, is not being associated with plaque, and and a lot of people on low carb diets have high uric acid. So it's not very clear to me whether or not a high uric acid is going to be a problem in people with a carnivore diet or a low carb diet. It looks like it may not be a problem, but in people who have metabolic syndrome, it really is a problem. So I'm not sure. I'd be interested in what you guys are seeing.
Did that answer your question?
Well, I would like to say that I'm thinking of a person that is metabolically healthy, has been keto or low carb for a long time. The consumption of fructose is minimum. And so that's kind of like a thing that shows up in, I don't know what to make of it, because it doesn't fit the profile. No alcohol.
So, okay.
So yeah, I obviously have a lot of experience with this. My uric acid level is actually normal range, which is kind of interesting considering I eat gazillions of pounds of meat every year. But what I tend to see, and I think it's like cholesterol. I think it can be a dependent variable. And I think when we look at like things like gout, which is what we commonly associate high levels of uric acid with, it depends on the inflammatory state, the metabolic health, temperature to some reason. Why do gout crystals deposit in our toes? Because they're colder. It's a simple chemistry dynamic. And so I will see, and for you guys that don't know, uric acid is actually an antioxidant. That's why we have it in our body in the first place. And so I just think it's a dependent variable. And so I think you can have relatively higher levels of uric acid and not see any deleterious effect depending on what else is going on. And so I think that's something that happens. And certainly, when you're metabolically, like as a surgeon, when I used to operate on gout and I would do gouty tophi, which interestingly, when you cut their skin open, it looks like a big tube of toothpaste you squeeze out there. It's kind of cool. But, almost every single gout patient I had components. Most of them were diabetics. I mean, most of them that I had to operate on they had some cell level, and probably if I would have tested them, they were hyperinsulinic or something like that. So I think it's a dependent variable.
Thank you so much.
Okay, there was a question from the live stream about reactive hypoglycemia, waking up in the middle of the night, hungry and low blood sugar levels. This person mentioned they have a CGM and they go to bed with a normal glucose level. They wake up at 2 in the morning and it's dropped 25 points. Can anyone comment on that?
So did I understand correctly? Hypoglycemia in the middle of the night? Reactive, yeah. So, actually, if you look at our cortisol levels, the diurnal rhythm of cortisol, we see that around 2 or 3 in the morning is when you have your lowest cortisol, and usually correlates with the lowest sugar of the day for diabetics. And then as cortisol rises, you start to see the increase. But also, you can also have like a reactive hypoglycemia that happens if you're eating a lot of, I don't know what this person's eating, but if you're eating a big meal, then you might have an insulin spike and then kind of crash. So that's also another component. So we do see the lowest sugars in all of us around 2 or 3 in the morning. And that's why also most type 1 diabetics have their biggest crashes around that time.
Hi, my name's Greg with Natural Life. We're out of Boulder, and my question is this. This is something that's very rarely addressed, but do you guys all know the work of Pottinger's cats? And the thing that I've asked a few people, and it's really not studied, I've been doing it for about 40 years, where I eat mostly raw meat and raw milk, about a half a gallon a day. And when you looked at the cats that had the raw meat but had any kind of cook or processed milk, within 3 generations, died off. They could no longer procreate. By the 2nd generation, they had terrible facial deformities, like cross teeth like we see in kids today. And by the 3rd generation, the males became docile and the females became aggressive, but some of the males became pedophilic and would rape and kill the kittens, but they would never go on. But the ones that were on raw milk and raw meat were perfect each generation. And if you took the ones in the 2nd generation and had them go all raw, within 1 to 2 generations, they completely went back to normal. And I wonder if anybody here has looked into that, and that by cooking our meats, especially too much, we could be damaging them or denaturing them in such a way whereas it's having a deleterious effect upon us. And if you guys can look at that, and I've been doing this for almost 40 years, and I'm thriving, so I want to know what you guys think.
Wow.
I don't look bad for almost 60.
That is impressive. I would say, I mean, I've read about this, and you probably know a whole lot more about this, but I would say for 99% of people, it's not relevant. They can get better uncooked meat because this is what we see in practice. But there's always that percent that doesn't get better, that maybe you're onto something here. So I'd like to hear what the others are.
Yeah, I'm not an expert in this area, but I know if you are overcooking meat, you can, like especially grilling meat, you get these advanced glycation like end products. And so cooking with oregano and thyme, so like specific types of herbs can improve that. But I don't feel like I know enough to be able to form more of an opinion than that. Perhaps my colleagues have more of an opinion.
Well, I am just actually curious about at what age of what is the age of consent for a cat? We have to pay for a cat, so I'm just obviously human beings are not cats, so we have to acknowledge that thing. And I don't know if Bill Schindler's here, but he can talk about when did we start cooking as a species. I think he'll mention it's something like 1.5 million years ago. Going back to Homo erectus most likely. So, I mean, we're adapted to eating cooked food for sure. I mean, are there advantages and disadvantages? I mean, certainly raw meats have been part of human culture for, beef carpaccio, steak tartare, sushi, sashimi. So we still do that. We still have the capacity to do that. And I think for most people, it's generally okay. I mean, provided you're cautious about the sourcing. I mean, I absolutely know people that have eaten raw meat on a carnivore diet, got infected, and had some really, really bad outcomes with that. So I think it's something to be concerned with. The whole pot, if it required human beings to eat raw meat to be able to reproduce, I mean, why do we have 8 billion people on this planet? So, I mean, so clearly that's not directly transferable. Might it have some benefit for some people? Yeah, sure, I would say so. But I think, again, I'm fairly agnostic about whether you want to eat it cooked or raw or, well done steak is kind of a crime. I would say that, but I mean, but generally, I haven't seen anything that's super compelling to me to say that all humans need to eat raw meat. Okay.
I think it's a phenomenal question. I'll just quickly comment. There's been some studies in Europe looking at children that drink unpasteurized farm milk, and they have compared to control groups where children are drinking ultra-pasteurized, homogenized milk, they have a lower prevalence of asthma, atopy, and allergies. So I think specifically in the context of raw dairy, if you were to choose ultra-pasteurized, homogenized dairy versus raw dairy, there probably is some health benefits. And the concern about listeria and other infections are probably quite low, so long as the sourcing, like Shawn said, is good. So in that context, I think there's benefits, but obviously, as Shawn alluded to, none of us would have been able to be fertile and procreate if eating cooked meat was damaging to fertility and building muscle and health. So I think with dairy, we're not cats, so dairy probably matters and species-specific context matters. But great question.
Thank you so much.
Hello, Renee Williams from Grand Junction, Colorado. I have a question about hormone and metabolic health and longevity. When you mentioned several times, Cynthia, that as people approach menopause, women obviously approach menopause, men don't do that. Can I say that here? Is that okay? Okay. Moving on. All right. As women approach menopause, estrogen is an important part, right, of brain health, of bone density, all those good things, and you're saying metabolic health. Is there a difference and a more protective factor between the different forms of estrogen, between estradiol, estrone, and estriol, as compared with testosterone?
It's like I opened up that can of worms during my talk. I have to accept it. I would say, based on my clinical experience, I think estradiol is the predominant hormone that I think is most important to replace when women, if appropriate, in perimenopause, but definitely in menopause. The 12 years without a menstrual cycle. Without opening up another can of worms, I won't talk about the Women's Health Initiative and why we have a whole generation of clinicians fearful to prescribe hormones. Patients are fearful to take it. But I do feel like estradiol in particular is the one that is most beneficial for insulin sensitivity and the one that I feel like my patients get the best outcomes from when it is actually repleted. Testosterone, I feel like you have to actually get the estrogen levels, the receptors optimized before you can add it. And that can be very beneficial for not just bone, brain, muscle health, but also body composition, which I know for a lot of women in middle age is a source of endless frustration.
I'll just quickly comment, and then that's a phenomenal question. I think DHEA is under-recognized in peri and postmenopause. A lot of folks don't test that. They look towards testosterone, estrogen, and progesterone, but DHEA for postmenopausal women is very important as well. So I would definitely look at DHEA sulfate and consider replacement. Actually, we'll go this side.
Hi, my name is Jan Hagström from Sweden. I'm an anecdote, N=1, you could say. I have a type 2 question. I'm a type 2 reversed with influence from all these rock stars. Thank you. And my question is, I'm at no meds at all. I've been suggested 3 meds. But in the longevity sphere, there's a lot of talk about metformin having benefits. Will I live longer with a little bit of metformin?
What was the question? Should we recommend metformin? I love metformin. I mean, it's in diabetics when you don't, it's a drug that we know fairly well. We've been using it for 100 years. It seems to improve. There is some interesting data. It's also very interesting in cancer. I'm not against it. Okay, I'm not against it, and sometimes I like to prescribe it if there's like a little bit of insulin resistance and the person is not interested in the diet. Or I think it's a good tool that we have, and I myself actually did some looked at the data of like thousands of patients, cancer patients, and definitely there I think. It looks interesting, although there are still controversial papers that contradict each other. And I think that there is data that in people who exercise a great deal, then maybe it's not a good idea to use metformin because of its mechanism of action. But I think metformin is a tool that can be used, and it's cheap. And it causes a lot of side effects, so that's the bummer with it. But they're not long-term effects. They're just.
So I'm generally, if you don't need to be on a drug, that's my general heuristic. Not why be on the drug. And as you pointed out, there is some negatives associated with adaptations to exercise to the mitochondria, gut side effects or problems with that. Most medications somehow are basically kind of poisons, and say basically, why does it limit our ability to for hepatic glucose production? Is that normal? It's an abnormal. It puts you in an abnormal physiological state. Now, if you're a diabetic and your blood glucose is too high and it lowers your blood glucose, isn't that effect beneficial? That's probably true. If you're no longer diabetic and you've gotten rid of diabetes and you like to exercise, I'm not convinced that metformin is going to make you live longer. I mean, there's some people that'll talk about that. Maybe they'll say berberine or something like that. But I'm of the opinion that if you don't need a drug for a clinical reason, then you probably need to just avoid it.
Yep. Yeah, I think we all have far too many drugs. I always thought, that if we took the whole world off all their polypharmacy, so most, they have 5, 6, we saw that case before with 10 drugs? So if we stopped everyone's drugs, probably 2% of the people would die. The other 98% would feel a whole lot better. So I'm not going to... my medical defense probably wouldn't agree with me doing that. But, I think anytime we can get someone off a drug, then we're better off.
I really appreciate the question. I think a lot of us are curious and we get excited about these novel compounds, whether it's metformin, low-dose rapamycin. But I think all of us shouldn't even consider that until we're lifting weights 3 to 4 days per week, walking after meals, prioritizing exercise, and then maybe microdosing these things periodically and not doing them long-term, but focusing on exercise. You mentioned, will I live longer? Yeah. A new study found that people who preserve lean muscle mass are less likely over a 5-year period of time to have a heart attack. So I think the best thing that we can do is move our bodies and work on preserving lean mass throughout life. grip strength. Shawn Baker has shared a lot of studies over the years about independent correlations with grip strength and all-cause mortality. So I think we should focus more on that, getting stronger, getting more physically fit, and not worrying about the potential or the potential benefits of these compounds that, as you just heard, do have side effects and complications, depleting B vitamins and much more. But great question. Let's go back over here.
My name is Eric Westman, Duke University. I realize, thank you for your presentations. We have an amazing array of backgrounds and research and clinical experience. And so with what I've read and what I do clinically and what I do personally, it may all be very different. So I'm wondering what you do, what your read of the literature is about measuring ketones. Do we have to do them? Is it good to do? Do you advocate that in your patient population, ketone measurement, or in any form? And I just have to say, I don't measure. Oh, and then do you measure your own ketones? Are you measuring glucose and ketones? Because you're a practitioner, you've read all these papers, and we all have our own way of kind of figuring out what we should do. And often what we do is different than what we do in our patients. And anyway, so do carnivores get ketones, for example, and do you recommend them in your patients, and then do you measure them clinically?
What do I do? Very little. I mean, I've been eating this way for 8 years, very low carb, probably ketogenic most of the time. When I check, I am in ketosis, but it's happened like just because I'm showing like a patient to check. It's individualized. This is, as you know better than anybody, the art of medicine. Some people want to check everything. Some people don't want to check anything. They want to be left alone. And my thing is that we shouldn't medicalize this so much. This is a diet, so it depends what you're treating it for. But I think, this is a way of life. So I'm not going to change what I eat, really, based on if I'm in ketosis or not. Because also it's a point in time, right? So, and, I think, again, it needs to be individualized, and I don't think it's necessary.
I'm a gadget person, so I'm the first person to admit that when I say this, I take it with a grain of salt. I think a lot of it is, I agree with you, bio-individuality. What is your patient like? Sometimes it provokes anxiety to have more data. Some patients are dated nerds like I am, and I want to know all the things. I personally don't check ketones. I focus more on glucometers and CGMs. And just helping people understand like the signs that will indicate they are in ketosis or they're becoming more fat adapted. And so I just find that I can motivate my women with a CGM or a glucometer if I need to, but I'm not typically checking ketones in my practice.
Yeah, I guess I'm a bit similar in that I don't do it routinely. But yeah, as was mentioned, I mean, some people really want to know everything about their health, but it's also as CGM, I mean, I think the great advantage of CGM is such an educational tool, because people learn what effect certain foods have on their glucose level. And similarly with ketones, you can measure the foods that kick you out of ketosis, that put you back into ketosis. So maybe even when you start a ketogenic diet, it can be quite helpful as part of your education process. But I certainly don't think it's necessary sort of long term.
Yeah, first of all, Eric, by the way, thanks for what you've been doing over the years. I mean, you've been a pioneer in this, and thank you for doing that. And I'm not laboring over the ketone research. I mean, I'm pretty lazy myself. I spend my time other areas. But given the fact that you can gain weight while being in ketosis, given the fact that your blood ketone level is a product of how much you produce, how much you utilize, and what's left over is wasted, and that variable is maybe unknowable. The times I've been checking for ketones, I produce a very small amount of ketones. I don't worry about it. Again, I got into that problem as an athlete. My goal was to throw things really far, and I was focusing on how much I could deadlift, which sort of correlated, but wasn't a direct thing. And so I think outside of, maybe epilepsy or maybe certain cancer treatments where you're really concerned about glucose ketone index and stuff like that, I think for most people it's probably, because it can be anxiety provoking, because what if they're not in ketosis and they think they should be, and then like, oh my God, they're freaking out, and then they derive some stress response to that. And then, so I think, keep the goal the goal. And most of us' goal is not to have a ketone of 2+, it's to lose weight or feel better. So I find it to be, kind of interesting. And by the way, they're developing, as you may know, they're developing continuous ketone monitors. They're coming out now. And what are you going to do with that information? It's just somebody's going to make some money on that probably, and we're all going to talk about it, and it's going to be, it'll just be interesting and kind of funny to see. But I'm a pretty simple guy. I'm an orthopedic surgeon, and they paid me to hit things with a hammer, and I kind of like to do things really simple.
Thank you.
Hey, Andrew Anderson, and so low carb for 7 years, decided to jump on the wagon of carnivore after listening to you, Dr. Baker, and Ken Berry in November. Was on it for 6 weeks, felt great. Physical performance went through the roof, mental performance is better. I decided to have one big cheat day, salad and fruit. I lost 50 IQ points, which left me with 2 the next day. I felt like crap for 3 days, joint pain and everything else. Can you explain any of the mechanisms on why that happened?
Yeah, all vegetables are poison.
I agree.
No, I think, you adapt, and like I said, it's the experience you share with feeling better and your cognitive performance and physical performance. I see it all the time, so I'm not, that's consistent with what I see pretty typically. I think, our gut microbiome changes in a day, or even in less, in a few hours, in fact. And so I think we developed tolerances to things like when you start out drinking alcohol, one drink and you're feeling tipsy, 6 years in, if you've been drinking a fifth of whiskey every day, one drink's not going to do anything to you. So we developed these tolerances to things. And so if whatever you're eating was, problematic for you, you just don't have the tolerance built up. So maybe if you slowly reintroduce stuff over time, you'll see that. We see that with like oral glucose tolerance tests, low carb people. If I take an oral glucose tolerance test tomorrow, I'm going to fail it. I'm going to have a blood glucose of 300. If you give me carbs for a week or so, I'll develop those, I'll upregulate enzymatic pathways and so on and so forth. So I think it's just a matter of those are abrupt transitions. And that's one of the dangers of going carnivore is you drop in something in there, even if it's a relatively healthy food, it can cause particularly GI upset and other things like that, and joint pain. And I think those all related to, an inflammatory response that occurs. So it doesn't mean you can never eat that again, but you just have to be mindful of it.
Gotcha. I think I'm just going to stick with the ribeyes, honestly. So thanks.
Too short. So my question is, I hear more and more about ketogenic therapies or carnivore diets as a way to reverse certain disease states like type 2 diabetes or immune disorders. So I've heard, and actually I think it was a video with Mike and Thomas DeLauer talking about a way of getting out of the ICU. So what's your take on using a ketogenic therapy or carnivore diet in order to reverse a disease state, but then do you recommend just prolonging the use of that therapy or keep using that diet and then do something else, or you think instead you should just stick with the carnivore diet for life?
Okay, I'll talk to that because I think it's a great tool. I think it's a great elimination diet. I think most people that I come in contact with who do a carnivore diet, they'll do it for a period of time, they'll fix whatever the issue is, and then they'll introduce food. And most people ever do it successfully, and I think that's fine. There are some people, however, that feel so good and they like it and they like the simplicity of it and they stick on it for years and years. And I think either's fine. I mean, quite honestly, I think you can live on just meat indefinitely. I think it provides everything you need. I don't think you'll end up with deficiencies. I've been doing it for basically 7 years and I'm not fading away. I'm not like nutritionally devoid, so. So, I mean, I know we're running out of time here and I'm sorry, but yeah, I think that if you approach it as a tool to heal something, it's much more easier to accept mentally. I'm going to do this for 6 months. I'm going to fix my problems, and then I'll take it, and then I'll reassess where I'm at. And I think one of the things is you have to be very methodical about how you reintroduce foods, and it may depend on what situation you're in, whether you had Crohn's disease or psoriasis or depression. They're all going to respond a little bit differently. That's where I think Amber O'Hearn, who's here, has made this really nice thing that we're all very similar human beings, but how we break can be very unique. And so if we're broken in different ways, then we have different tolerances afterwards. So yeah, I think I always encourage people to, once they've solved their problems, hey, give it a try. Try to reintroduce. Some do, some don't. Some do it fine. Some have problems. But yeah, it doesn't have to be a lifetime thing.